And now we move on, we change gears from surgically managing to how do you give good functional outcomes. And I'm very happy to invite Dr. Aditya Sethi, who will be talking about paradigms of strabismus management in patients with pediatric cataract.
Thank you so much, ma'am. I would like to thank ma'am for giving us the honor to be part of this illustrious IC with such great pediatric cataract surgeons on board. So you saw what was happening with pediatric cataract surgery was only 25% of the real war. The next 75% is actual, what like how Dr. Jagadram sir said, is the follow-up and how we rehabilitate them. So first and foremost, we'll talk about is strabismus. A lot of our cases which come to us either with unilateral, especially pediatric cataracts, we've seen either come with a strabismus along with the pediatric cataract, or they develop a strabismus as time comes if the rehabilitation is not done properly. And sometimes even with the best of rehabilitation, still they end up with strabismus. So we know congenital cataracts are very common. It's rare, but about 2.2 to 3 out of 10,000 newborns have it, and it's a global issue, and we need to intervene as early as possible. And there often are complications to the surgery as well, which could also mean glaucoma, strabismus, excessive inflammation thereafter. So these factors of developing a strabismus after pediatric cataract surgery include if the child already has a pre-existing nystagmus, anisometropia, poor post-op visual acuity, often unilateral cataracts, and this all impacts in the real life scenario, which is binocular vision, because often the child prefers one over the other, and that leads to a lot of limitations in the child's life. So prevalence of strabismus is actually a post-cataract surgery is recorded from a wide range. It was actually less than 4% to about 86% in children who are post-cataract. And so far it's much more than the normal 0.4 to 1.299% of strabismus which we see in general population in non-pediatric category. It's more common after unilateral cataract surgery, and its association with IOL is also being established, but that is again controversial, with some saying that there's no preference if you leave them aphakic or not. But in a lot of studies we say when we put an IOL, it's actually better for not having strabismus later on. So a lot of literature research has revealed a lot of retrospective analysis of this. So we decided to do a little bit of our own. So we went back and checked how it was happening in our center, where we found out that it was actually quite common as time goes on, and it was actually reaching around 18%. So it was actually there, and a lot of these cases were actually undergoing a secondary strabismus correction. So that was also reported in IITS, a spin-off of IITS, toddler aphakic and pseudophakic treatment studies. And we've seen that unilateral cataracts actually have the higher rate. So again, more literature review, we're talking about how pseudophakic versus aphakic, we've noticed that pseudophakics did better, especially with now the advancing lenses and the advancing techniques of preventing any visual axis opacification. And comparison with other studies, we've noticed that the horizontal muscles were often the culprits. It was more of a ESO and exotropia than a vertical or any other problem. And all of this led to figuring out that maybe we need to put more earlier cataract surgeries. We have to need to follow them as much as we can. We have to do a proper visual rehabilitation, think of amblyopia management. Even nowadays dioptic therapy and other stimulus can be provided. So these are the management options we have. The correct refractive correction, we have to go ahead and do amblyopia therapy. We also have now binocular visual rehabilitation, stabilization, orthoptic corrections, and then if that all that doesn't work, then we have strabismus surgery. So still we have a lot of questions unanswered. Should we always target emetropia or near emetropia, especially in unilateral cataracts, to prevent a strabismus later on? Should we use something like an EDOF or a multifocal lens to get good binocular vision, maybe more so for near, and get the use going earlier? What all sort of amblyopia therapies are actually preferred here, and does modern day pediatric cataract surgery actually prevent visual axis opacification later on, and binocular vision therapy applications, how does it affect? So I'll take cases. First case is actually a 7-month-old child with a unilateral cataract. We did a good pediatric cataract surgery that's already been described. Follow up, we saw that there was a correction with refractive glasses was given, amblyopia therapy was started. After 8 months, we started noticing there's an exotropia. So the child started having an exotropia. You can see that's quite right prevalent there. And then amblyopia therapy was increased further. And orthoptic treatment was established. After 18 months dioptic therapy, you see we've actually hit the target and went closer to the other eye refraction, so there was not much to talk about there. And in about 3+ years, the child is doing much better, well aligned, by just doing the correct visual axis opacification. So a lot of times it resolves by doing the correct thing. In the second case, this is a 2-year-old with a pediatric cataract unilateral, again went for the same lens aspiration, PBC antivitrectomy, left eye recovered well. 1 month we started seeing refractive correction with glasses was given, started appropriate patching. 2 years follow-up, you can still see it's quite established esotropia of large angle. So we did follow-up, and then as time goes, as the child grows older, we decided to intervene earlier, and we did a esotropia correction with a bimedial recession. So this is just a quick video just to show everybody how we do the phonics based, if time permits. So should I? Yeah. So it's as simple as any other recession that we generally do in pediatric cases. We prefer the phonics incision, hides the scar well. So in the 8 millimeters away from the limbus, you will make a phonacial opening, and then you go ahead and you tag the medial rectus muscle. You put your sutures, then you mark your point you want to reinsert the muscle, and then after that's done, it's a very simple, straightforward closure and leaves no scar. So this was done in both the eyes to get good cosmetic correction for the child, and the child did well. Third case, this is a case with pediatric cataract, which is unilateral. Again, it came at 6 years of age, so the parents were delaying surgery. The parents were delaying the vision in this eye, saying the child was doing well with the other eye. So already had a large angle strabismus with a V pattern already set in. So first thing we did was went ahead and did the pediatric cataract surgery. On repeated follow-ups, the child visually did well, but the strabismus was pretty much there. And sorry, I don't have exact photos of this, but I'll just show a quick video of how we tackle the inferior oblique. Again, after going ahead with a phonacial opening, we first tag the lateral rectus muscle, and once that's tagged, if you have a good assistant, you can do that, or you can put a suture there. And then you go ahead and look for the inferior oblique. Make sure you get the complete inferior oblique, and after you completely isolate the inferior oblique, then it's pretty much simple. This muscle is not going anywhere. You cut the head of near the head of the inferior oblique. You take your sutures, and then in inferior oblique recession, especially if it's only 2+, I prefer to do a insertion 2/3 laterally and inferiorly to the muscle, inferior rectus muscle. So that does a good job as well. So thank you. I hope I was able to cover most of the points, and if you have any questions, we can take some.
So Aditya, I have a question. Let's say there is a child who has bilateral cataract surgery, but has one eye doing better than the other, and obviously now develops a squint, which was already probably there. What is the age or what time point after the cataract surgery would you start thinking of squint surgery?
So two things. Number one, if the vision is doing well, if both the eyes are seeing well and the child is alternating well, then you treat it like an alternating convergent squint, and then you plan your intervention as early as say 6 or 7 years, or maybe before binocularity is established completely. But currently we are seeing is, even with these cases, they do resolve even non-surgically if we are patient enough. So it's just about the follow-up. A lot of us come from places where we don't have good follow-up with these patients, then we are a little more aggressive. But if you have a good follow-up, the parents understand, I think if you follow up, they do pretty well with time.
Yeah.
So generally, when you say follow-up, we're going to be measuring the patient on each visit, and once you feel maybe over a 6-month period of time that the angles are remaining stable, vision is stable, you would probably... Yeah.
So I think the message that I'm getting from both of you is do aggressive amblyopia therapy, repeat your assessments frequently and document the angle, but if it's stable and if the vision is anyway not improving, then earlier surgery may not be a bad idea.
So I think vision is the first criteria,
Yes,
because your angle would really change depending on the vision. So if there is potential for amblyopia therapy, you would definitely focus on that before the squint surgery, because the angle really varies based on the vision.
And these are not normal eyes generally,
Yeah,
and
absolutely.
so there can be other involvements of nystagmus or a posterior segment anomaly, and that changes the way you approach them.
And if it is a sensory squint, of course, what you said, you really do have to counsel about overcorrection, undercorrection, and repeat surgeries, much higher incidence. Aditya, I had one question, sorry.
Yeah, ma'am.
In one of your cases, you had mentioned in the 3-year-old child, dichoptic therapy for the 3-year-old child.
Yeah.
So what dichoptic therapy?
So nowadays we have iPad-based dichoptic therapy, which is recently available. So getting to that, I've noticed children are very good with tablets. So they are more visually there. We also, before this, when this was done, actually we had that option of a polarized screen and a polarized glass.
Yes.
So that worked better in younger children. They would watch a movie or otherwise. It was like an alternative to patching, not exactly dichoptic, but there.
Yeah.
Yeah.
No doubt, I mean, the management is very appropriate, but it also depends on the amount of deprivation amblyopia the patient has had. So if you operate a infant versus a 1 year versus a 2 year, a unilateral cataract or a bilateral cataract, all these would factors which would come up when you're managing these patients.
Yeah.
The other thing is there could be gross anisometropia which one has to tackle. So if you tackle that anisometropia, maybe a lens exchange or maybe some kind of other things, it could help in improving the visual acuity. The third is in young children, we often do retinoscopies and sometimes we might be missing out on subtle visual axis obscurations. So that is very important to see in these patients.
Okay.
So everything is not just, I mean, just a patient comes with the strabismus, you just evaluate for strabismus and do surgery, but the cause, the pointer why it's going has to be, basically that is the first thing we have to find out and appropriately manage, as you've rightly said.
Correct. Right, sir.
So I think the whole message is key is follow-ups technically to look for anatomical complications and complications that may be having functional effects. So repeated follow-ups and if needed, as was mentioned, you may need to do an EUA to rule out fine visual axis obscuration. So I think
one comment. It is very significant number of these children, they have strabismus.
Yes.
We never realized initially because as Dr. Jaspreet said, he said that the more there is a amblyopia, more there is an isometropia,
Yes.
correction of that first, and then of course we do it like this as you said, you also
Yes, sir.
said.
Correct,
So it is a very, very significant problem,
Yeah.
and solution is required.
Correct.
thank you. And now we move on to the last, but I think one of the most important topics of how do you deal with amblyopia and visual rehab in these children, particularly when patching may not be working or compliance may be an issue. So